Our next session is by Dr. Deepa MG, Associate Professor, Government Medical College, Ernakulam, glaucoma in trauma.
Getting the mic ready after Minusar's talk, bringing it down from so high. So I'm Dr. Deepa talking about glaucoma in ocular trauma. So the causes of raised intraocular pressure in trauma can be early onset causes and late onset causes. The early ones are hyphema, inflammation, trabecular damage, lens-induced, massive choroidal hemorrhage, and chemical-induced changes. And the late causes are a chronic angle closure due to peripheral anterior synechiae, angle recession, ghost cell glaucoma, some lens-induced changes, intraocular foreign body, cyclodialysis, retinal detachment, and epithelial downgrowths. So taking one by one, being the common causes first, we all know that trauma in causing uveitis is the most common cause for a secondary glaucoma. It is seen in around 20% of cases, the mechanism being the debris clogging the trabecular meshwork and causing trabeculitis. The IOP may be reduced sometimes if the ciliary body is disrupted or shut down. The treatment is topical steroids along with anti-glaucoma medications, and if persistent, rule out intraocular foreign body or systemic causes for the uveitis. Now, hyphema is the next important cause for a raised IOP. It can be due to the blood coming in from the tears in the iris and ciliary body. The mechanism being the RBCs clogging the trabecular meshwork, increased viscosity of the aqueous due to proteins, trabeculitis, and the large hyphema sometimes may be causing a pupillary block. Late onset glaucomas can be hemosiderotic, hemolytic, ghost cell, etc. This is especially dangerous in sickle cell traits where the high IOP can be there even with a minimal hyphema, and optic nerve damage can be earlier. A late onset glaucoma, which is very common after trauma, is angle recession, where there is a separation between the circular and longitudinal muscles of the ciliary body. There is hydrodialysis, cyclodialysis, hyphema, sphincter tears, etc., which is associated. If it is a less than 180 degree tear, glaucoma is unusual. If it is more than 180 degree angle recession, the patient needs yearly follow-up for late onset glaucoma. If it is more than 240 degree, then there is a high risk for glaucoma. The treatment is by giving anti-glaucoma medications, but usually it may go into something like primary open angle glaucoma, leading on all the management modalities used in the same. The lens getting subluxated or dislocated can also cause a rise in IOP, especially when there is more than a quadrant of zonular damage. The anterior subluxation causes pupillary block, and it can cause angle closure also. There will be iridodonosis, phacodonosis, irregular depth of the anterior chamber, and sometimes the equator of the lens may also be seen through the dilated pupil. The treatment is a laser iridotomy to relieve the pupillary block, and later on lens extraction with IOL implantation. In chemical injuries also, raised IOP is very common. There is a bimodal pattern in the rise in IOP due to the prostaglandin release, or later on it can be due to the scleral shrinkage or due to peripheral anterior synechiae formation. Sometimes in intraocular foreign bodies, there can be siderosis and chalcosis causing deposition in the trabecular meshwork, leading on to a late onset glaucoma. The treatment is to identify the foreign body with a gonio, fundus evaluation, CT imaging, and then removal of the foreign body. Another late onset glaucoma is ghost cell glaucoma, usually following a vitreous hemorrhage, where the RBCs become ghost cells. That is, they lose the biconvex shape and pliability and become spherical, depigmented, and rigid. They come into the AC through the disrupted anterior hyaloid phase. The treatment is anti-glaucoma medications, and later on they may need trabeculectomy. Hemolytic glaucoma is also due to the byproducts or the degeneration products of the blood getting into the trabecular meshwork and then causing a glaucoma. This occurs weeks to days after the primary hyphema. The treatment is anti-glaucoma medication. If it is in very few days, you can do an AC wash. Sometimes this may lead to even a vitrectomy or a trabeculectomy. The complications related to hyphema and other blood-related complications are optic nerve damage if the IOP is remaining more than 50 for 5 days, if it is more than 35 for 7 days. And there can be corneal blood staining, peripheral anterior synechiae formation, and there is a chance of rebleeding, especially in sickle cell trait patients. Surgical intervention may be required if the IOP is remaining more than 60 for 2 days, if it is more than 50 for 5 days, and if it is more than 35 for 7 days. In sickle cell, the IOP range will be slightly lower. If it is more than 25 for more than 24 hours also, we have to think of intervention. And when corneal blood staining is persistent for more than 10 days also, and in large hyphema in children. The procedure can be a simple paracentesis, irrigation and aspiration, or sometimes when there is a large adherent clot through a large limbal incision, manual expression, cycloextraction using vitrectomy instruments, or even ultrasonic emulsification. In other cases where an acute hyphema is there, conservative management with a head and elevation and bed rest, topical steroids, cycloplegics and anti-glaucoma medications should work. You can also give antifibrinolytic agents like tranexamic acid. Patching may be done to prevent sunlight converting hemoglobin, and photocoagulation of bleeders with a gonioprism may also be tried. The less common causes of glaucoma include Schwartz glaucoma in RD by the outer rod cells coming to the anterior chamber. Sometimes the epithelial downgrowth in penetrating injuries can lead the epithelial cells abnormally into the anterior chamber, leading to formation of pearl cysts or membranes. Fibrous ingrowth, electrocution leading on to pigment dispersion, radiation causing NVGs later, periocular trauma are all other conditions. There are some low IOP glaucomas also following trauma, especially when there is a cyclodialysis or a trabecular tear where there is a disinsertion of the trabeculum from the valves. Later on, sometimes a glassy membrane will form over this gap and the IOP may rise. So these are the common conditions leading on to a raised IOP in trauma. A better understanding of this can be very handy in your general practice. Thank you.
Thank you, Dr. Deepa.